Okay, so hello and welcome to iTenev's webinar. Today we're going to be presenting on the Meaningful Use Final Rule. This is the 15th installment of our educational webinar series. We know that it's an important topic for everyone, and we hope that you find it useful and informative. My name is Chelsea Grover, and I'm the Marketing Communications Coordinator for iTenev. I'd like to take a moment to explain the process for today's presentation. First, I'd like to mention that this webinar will be recorded. Next, I'm pleased to announce that we're mixing up our normal routine for the next webinar by doing a four-part series covering government regulations and ramifications. The first one is on November 11th and covers meaningful use audits. Then we will help you prepare for the audit, decipher and highlight key information to have in your audit binder. Then on October 18th, we're going to be discussing EHR cloning. What is it, who's committing it, and how it affects your practice, and other important information. Then in December, we're going to cover the dangers of information blocking and its effect on interoperability. Gosh, I can't say that word today. Where we will help you discover if you are the victim of it or perhaps even participating in it, common practices, and how to combat it. Our final one in the series will be on high-tech security and HIPAA, and that will also likely be in December. Exact dates for the last two still remain to be set, but follow us on social media, check our website, or keep your eyes out for emails from us for the set dates. Okay, so back to our current webinar. At the end of the presentation, we will open the floor up to questions from you. We will answer all the questions at the end, but you may type them in the questions area of the webinar control panel whenever they occur to you. For your reference, we will be also be emailing links to the recordings of PDF and the presentation later this week, as we do with every webinar. Finally, for audio clarity purposes, everyone's phone will remain muted throughout the entire webinar. If you experience audio issues, please use the chat box to let us know so we can resolve them. And again, questions may be entered in the questions box. So without further delay, I'd like to introduce our presenters for today, Lindsay Lanning, Kathy Thompson, and Cindy Kincaid. Lindsay originally joined us from the Ohio State University intern program, where she was getting her degree in Health Information Management Systems. After graduation, Lindsay joined our team as the Healthcare Informatics Coordinator, where she spends most of her time immersing herself in the ever-changing healthcare IT environment and educating the rest of the company on new issues and trends in the industry. Kathy has been with iTenev for 10 years. Prior to joining iTenev, she was a medical assistant at a neurosurgical practice. This was where she got her first taste of Nextgen and has been hooked on it ever since. Currently, she is a managing consultant at iTenev, where she specializes in Nextgen EHR and incentive programs. Over the last 3 years, she has become a meaningful use subject matter expert, along with working nonstop with our clients. Cindy is Vice President of Consulting Services at iTenev and a Certified Practice Management Executive. With over 25 years in the IT healthcare industry and 9 years with iTenev, her experience runs wide and deep. This makes it possible for her to provide the insight needed to help healthcare organizations experience great success, no matter what the challenge is. Okay, so Lindsay, I'm going to go ahead and pass the webinar off to you. Feel free to get started when you're ready.
Thank you, Chelsea. Hi, everybody, and thank you for taking time out of your busy week to sit in on this webinar regarding the finalized meaningful use rules. So the Centers for Medicare and Medicaid Services and the Office of the National Coordinator of Health Information Technology published a long-awaited final regulation that includes modifications to the Stage 2 of the EHR Meaningful Use Incentive Program. It outlines requirements for Stage 3 of the same program, specifies testing and certification criteria for EHR vendors for 2015, and finalizes the government's interoperability roadmap. This is a lot to come out at just one time. Originally, the proposed Stage 2 and 3 rules were actually separate, but were released together in one final rule. So instead of looking at the entire rule and all of its parts, we're just going to look at the modified Stage 2 for 2015 through 2017 in detail today. We will look at Stage 3, but very briefly, and focusing on the changes that were made and the important facts we need to know now. I do want to preface, even though this is only 1/4 of the final rule, it is a lot of information with a lot of technicalities and details involved. So I will try to go as slow as possible as I can through this, and hopefully I will be able to leave you with a full understanding of what meaningful use will be like from now until 2017. So let's get started. Like most news we get in our life, there's usually a piece of good news and a piece of bad news. And basically this rule is no different. The good news, we finally know exactly what we need to do. We now know we have 10 objectives for eligible professionals, including one public health reporting objective that we must attest to. That was one of the hardest parts, playing the guessing game for the last 6 months of what would stay and what wouldn't from the proposed rule. So I think it's good news that the information is finally available and we can now know exactly what is expected of us for the next 2 years. And the bad news, it does require a lot of changes and stringent timelines. CMS states repeatedly it is trying to reduce the burden on professionals and increase flexibility with this new set of objectives, but bottom line, it is a complete program overhaul, and providers will have to adjust to the new objectives, measures, and timelines. And per usual, we're already behind before we've even gotten started. In order to take advantage of the 90-day reporting period offered by this final rule, providers' last day to start a new reporting period was October 3rd. This is because it has to be any continuous 90-day period in 2015. So meaningful use data collection has to be completed by December 31st of this year. So if the last day to begin the reporting period was October 3rd, and the final rule came out on October 6th, I guess we aren't the only ones who are behind. So what has happened since the proposed rule? Well, there has been pressure, and not just in regards to the time crunch CMS put on itself with the 90-day reporting period. No, I'm talking about the pressure from external organizations and industry stakeholders. There have been 6 separate times over a 4-month period where industry stakeholders, hospital associations, provider associations, and even Congress have published letters or press releases calling for the proposed rules to be finalized and/or delayed. With groups like MGMA, the Senate Help Committee, 100+ members of Congress, and the AMA pooling support and calling on CMS to take action, it added a lot of pressure and did eventually lead to the release of the final rules. There has been new legislation. So this new legislation has been introduced, and it would modify Stage 2 and delay Stage 3 meaningful use. This bill, called the Flex IT2 Act, points out 5 provisions. Delay Stage 3 rulemaking until at least 2017, unless at least 75% of EPs and hospitals are successful in meeting the Stage 2 requirements. Harmonize government quality reporting requirements to remove duplicative measurement and streamline requirements from CMS. Institute a 90-day reporting period for each year, regardless of stage or program experience. Encourage interoperability among EHR systems, and expand hardship exemption categories. This bill was introduced on July 29th of this year and was passed to a subcommittee, but it has not passed the House or Senate as of today. And then we also have the Medicare Access and CHIP Reauthorization Act. We will not go into detail regarding MACRA, but in very broad terms, it was signed into law on April 16th of this year, and it repealed the Medicare Sustainable Growth Rate. It also streamlines existing Medicare quality reporting programs. MACRA ends physician payment incentives under the Meaningful Use Program and those under the Physician Quality Reporting System, as well as the Value-Based Payment Modifier, replacing the incentives in those programs with a new program called Merit-Based Incentive Payment Program, or MIPS. Now again, I don't want to go into detail over this legislation in this presentation, but it is important because of how this affects meaningful use right now. The proposed meaningful use Stage 3 regulation was developed prior to and without consideration of the changes enacted by MACRA. Yet, the Meaningful Use Program will play a vital role in both the new MIPS payment system and the development of APMs. MGMA and other healthcare organizations are requesting that the administration pause Meaningful Use Stage 3 and reevaluate the program in light of these pivotal changes to Medicare. But we will see later on, this is the reason for the comment period that has been added to the final rule. There have been changes from the proposed rules. So first off, the 90-day reporting period was extended for not only 2015, but for all new meaningful use participants from 2015 through 2017, as well as providers who choose to attest to Stage 3 in 2017. The following Stage 3 objectives had measure thresholds that were reduced, and those are for CPOE, e-prescribing, and coordination of care. And finally, public health reporting requirements were decreased from having 5 possible measures to only 3, with the provider attesting to 2 out of those 3 for the modified Stage 2. Now let's take a look at the Meaningful Use Modified Stage 2 Final Rule. On April 10, 2015, the Centers for Medicare and Medicaid Services issued a new proposed rule for the Medicare and Medicaid Electronic Health Record Incentive Programs. Now, here we are 6 months later on October 6, 2015, and CMS has finally released the final rules that simplify requirements and add new flexibilities for providers to make electronic health information available when and where it matters most, and for healthcare providers and consumers to be able to readily, safely, and securely exchange that information. CMS states, in recognition of the many concerns voiced, the final regulations make significant changes to current requirements by easing the reporting burden for providers, supporting interoperability, and improving patient outcomes. So what's changing? Well, the modifications to meaningful use set forth by this modified Stage 2 final rule are it changes the reporting period requirements for 2015 to a 90-day period, and it aligns it with the calendar year. In 2015, providers need to report on their use of EHRs for any continuous 90 days within the calendar year, and they need to attest by February 29th of 2016. It also changed the reporting period for 2016 and 2017 for providers that are new to the EHR incentive program. They will have the additional flexibility and can report on any 90 days as well. And again, anyone who chooses to attest to Stage 3 in 2017, this is when it is optional to either stay in Modified Stage 2 or go on to Stage 3, will also get to report using a 90-day period. They are allowing any continuous 90-day reporting period. This means it's not tied to a quarter, but you do have to complete the reporting in the same calendar year. So you can't start in December of 2015 and then finish in February of 2016. This modification was really causing the most stress for everyone because of the time crunch to get the final rule out so providers could start attesting and utilize that 90-day reporting period. CMS is encouraging providers to apply for exemptions if they experience challenges due to the timing of the rules and the EHR implementation. This rule also modifies patient action measures in Stage 2, objectives related to patient engagement. I know we've all been waiting for this. This hasn't changed, and it's going to be a major improvement for everyone. It also removes reporting requirements on redundant, duplicative, or top-down measures, therefore reducing the overall number of objectives. And finally, it modifies public health reporting requirements. Here we will see a decrease in measures compared to what we had in the proposed rule. Purpose of modification. So why are they doing this, and why change things now? CMS has heard from physicians and other providers about the challenges they face making this technology work well for their individual practices and for their patients. In recognition of these concerns, the regulations make significant changes in current requirements. They will ease the reporting burden for providers, support interoperability, and improve patient outcomes. For example, the regulations reduce the number of objectives from 20 to less than 10 and provide a flexibility so that providers may choose measures that are most relevant to their practice. There is now that 90-day reporting period for 2015 and extending that reporting period for new providers in 2016 and 2017. And then the new effective date for Stage 3 is 2018, making the program optional for providers in 2017. This gives providers and states more time, 27 months to be exact until January 1st, 2018, to comply with the new requirements and prepare for the next set of system improvements. This also gives developers more time to create the next advancements in technology that will be easier to use and more appropriate to new models of care and access to data by consumers. So to reiterate, they did this in order to scale back and try and make things easier on providers, as well as streamlining the program for the future. Changes to participation timeline. So it's important to understand with this rule there will be participation changes and reporting changes made. This graphic gives a great high-level view of the changes to the participation timeline. And you can see in 2015, providers will need to attest to the modified version of Stage 2 with accommodations for Stage 1 providers. So everyone will be testing to this modified Stage 2 unless 2015 is your first year of meaningful use attestation, then you have the exceptions and accommodations made for you. In 2016, everyone should be attesting to the modified version of Stage 2. In 2017, providers can attest to either the modified version of Stage 2 or the full version of stage 3. So this is going to be a flex year. You will have the two options, and it will depend on your EHR certification criteria, which we'll touch on later. And then in 2018, all providers should be attesting to the full version of stage 3, which is the final stage of meaningful use. So stage 1 and stage 2, as we know it, are no longer, although there are the alternate exclusions with most measures for providers in stage 1 in 2015. When you attest, the attestation program will know what stage you're in, and they will offer you the alternate exclusions and specifications that apply to you if you were going to be in stage 1. It's important to note you don't have to claim the exclusions if you don't want to, and you also don't have to make a global decision. You can select measure by measure which alternative you want to take advantage of and which ones you may not have to. So back to this idea of 2017 as a flex year. Meaningful use stage 3 was originally slated to begin in 2017 for providers that had completed stage 2. Now 2017 is a flex year. This means that providers who would have progressed from stage 2 to stage 3 in 2017 now have the option to stay in stage 2 an additional year. Only providers who use an EHR certified to the 2015 ONC standards will be allowed to attest to stage 3. However, if you do attest to stage 3 in 2017, you are now being offered a 90-day reporting period. Every provider will be meaningful use stage 3 in 2018, even if 2018 is the provider's first reporting year. In order to simplify the meaningful use program, all providers will be in the same stage at that point. All providers will also be using EHR certified to the 2015 ONC standards. So to clarify, for modified stage 2 EHR certification for 2015 to 2017, providers can only use EHR certified to the 2014 standards. There's no flexibility like last year where you could use previous criteria. Now you have to use CERT to the 2014 standards. This shouldn't have a huge impact. Almost everyone is currently using this criteria. And like I said, you can adopt the CERT to the 2015 standards prior to 2018 if you desire. It's not required. But the catch is, if you do want to adopt stage 3 early and take advantage of that 90-day reporting period for 2017, you do have to have that 2015 criteria met. I know it's been a real pain to keep up with all the changes being made in such a short period of time. It's hard to know exactly what's expected from your practice and at which stage or set of criteria you should be using. So this is really trying to simplify this program and get us all on the same page within the next few years. So in order to help you with this, I really like how this chart shows you kind of the stages, and it allows you to pick which year you first attested as a meaningful user and which stage you will be required to attest to each year. As you can see, if your first year of attestation was 2014 or 2015, and you were planning on demonstrating stage 1 meaningful use in 2015, you'll have those alternate exclusions and specification for certain objectives and measures. What this means is that stage 1 meaningful use is essentially gone with the additional exemptions I mentioned, and then stage 2 and stage 3 are the only meaningful use stages available for attestation from here on out. So that wraps up all of the participation changes with the final rule. Now we're going to go over the reporting changes. Again, I know this can be a lot to take in and dissect all at once, so to break it down for you, in 2015, all providers will report for any continuous 90 days. You must have this completed by December 31st of this year, but you don't have to actually attest until February 29th of 2016. In 2016, all first-time attesters will be able to report for any continuous 90 days, while all returning providers will need to report for a full calendar year. In 2017, again, all first-time attesters will be able to report for any continuous 90 days, as well as providers who are attesting to stage 3 in 2017, while all returning providers will need to report for a full calendar year. And in 2018, all providers will be reporting for an entire calendar year. Now, having gone through all of the participation and reporting guideline changes, we reach the main goals of this rule. And they are to align with stage 3 to achieve overall goals of the program, synchronize reporting period objectives and measures to reduce provider burden, continues to support advanced use of health IT to improve patient outcomes by focusing on interoperability and advanced EHR usage. Align with the new macro law, and get all providers to the same place in meaningful use. I mean, this is the whole point. It's to streamline efforts and to get everyone on the same page so improvements can be made through the advanced use of health IT. To elaborate further on that first goal let's look at how this rule aligns modified stage 2 with stage 3. So this rule reconciles measures to align the new modified stage 2 with stage 3 by preparing providers to report stage 3 criteria in 2018, by reducing the provider's burden and creating a single set of sustainable objectives that promote best practices for patients, and by enabling providers to focus on objectives which support advances the use of health IT, such as health information exchanges, consumer engagement, and public health reporting. So what do these final objectives actually look like? Well, there is the core and menu concept change. So because of the restructuring of measures, the concept of core and menu will be discontinued in favor of choices within certain objectives. The new reporting structure is outlined below. So with this chart, you can see what we're all used to on the left with the core and menu objectives, and then what was retained to make up the new final set of objectives for modified stage 2. CMS has eliminated the distinction between core and menu objectives, and all the retained objectives would be required. What this does is simplify the structure by decreasing the amount of overall objectives and making sure everyone is attesting to one single set of measuring objectives. The removed objectives were identified by CMS as either redundant, duplicative, or topped out, and will no longer require attestation on them. And these are the ones listed below. CMS states that many of these redundant, duplicative, or topped out objectives and measures may be valuable to providers and patients. They encourage providers to continue to conduct these activities if it suits their practice and patient population. CMS says this because any measures that are topped out just mean they're so widely met and exceeded by providers, there's no longer a need to mandate it. But if it's adding value to your practice, it's encouraged that you continue doing them. They explain further, saying the removal of these measures is in no way intended as a withdrawal of endorsement for these best practices or to discourage providers from conducting and tracking these activities for their own quality improvement goals. Instead, we would no longer require providers to calculate and attest the results of these measures in order to demonstrate meaningful use for 2015. So keep doing these if they are working for your practice, but you no longer have to calculate and report on these. Changes to meaningful use objectives. So changes made to objectives listed below will be effective for EHRs reporting for EPs beginning in 2015. That's the patient access objectives and the public health objectives. So this is what we're really excited about. These changes try and decrease instances where providers don't have control over an objective's success. Provider control can be negatively influenced by measures that rely on the cooperation of patients. Providers don't have direct control over what their patients do or what they're going to do, so these revisions really hone in on what the provider does and not patient actions. So the changes to patient access objectives. This changes the threshold that more than 5% of patients must view, download, or transmit health information to just one patient needing to do so. It changes the threshold that a secure message must be sent using electronic messaging of CERT by more than 5% of patients to just having secure messaging fully enabled. Again, taking that patient participation factor out, since it truly is out of the provider's control if this is successful or not. And it will really help. I think it will make a big difference for those who have not been able to comply with this objective before. This objective is changing to self-attestation, which means providers will be responsible for saving all documentation needed to support attestation, such as a screenshot using a test patient in the patient portal that's dated to show secure messaging was enabled. Changes to public health objectives. So a stage 2 provider is required to successfully engage in any combination of 2 public health measures, unless through exclusions less than 2 options remain. A stage 1 provider is required to successfully engage in 1 public health measure, unless all exclusions are met. This consolidates all public health reporting objectives into one objective with measure options, following the same structure of Stage 3 public health reporting. This gives providers the freedom to pick and choose what best suits their practice while also aligning with Stage 3 objectives. This, again, is also changing to self-attestation objective, which again means the provider is responsible for all documentation, which will be a bit extensive, especially if you are proving your practice falls under an exclusion for any public health measure. We'll go into greater detail on these exclusions when we go over the modified Stage 2 public health objective. So after all of these changes, what will 2015 look like? Well, providers will attest to a single set of blended Stage 1 and Stage 2 objectives and measures. There will be no core menu measures. And this single set of blended objectives is being called the modified Stage 2. All reporting will be for 90 days. Accommodations by multiple exclusions and alternative measures within individual objectives will be made for providers who would have been in different stages of meaningful use, so Stage 1 in 2015. CQMs will be reported electronically or attested to, and the CQM 90-day period doesn't need to coincide with the 90-day MU attestation period. It can, but it's not necessary. Finally, CMS has recognized the release of the rule is late, but they assumed everyone was working on this already and have not extended the 2015 deadline. They have, however, created these alternate exclusions within each objective for those who would have been attesting to Stage 1 this year. They believe that this flexibility will allow 2015 reporting to be successful with the new, more reasonable thresholds. Whether this is the case or not, we are expected to report modified Stage 2 this year. So let's take a look at the final rule. So we will go through each objective and measure for the modified Stage 2. I will read through the objectives and measures, followed by an explanation and some other information provided by CMS to better understand each objective. And then I will ask Cindy or Kathy, who are also on the line, to jump in at the end of each one to hit on some key Nextgen information pertaining to the specific measures. So the modified Stage 2 objectives. The final meaningful use modified Stage 2 rule includes 10 objectives. Some objectives are subdivided into multiple measures, but the final objectives with their new names and numbers are listed on your screen. So let's go ahead and get started breaking down each of these. So protect patient health information. The objective, protect electronic health information created or maintained by the CERT through the implementation of appropriate technical capabilities. The measure, conduct or review a security risk analysis, including addressing the security, including encryption, of data stored in CERT, and implement security updates as necessary, and correct identified security deficiencies as a part of the provider's risk management processes. This is no exclusion is involved with this. So this objective and measure has a minor modification to the title, as it is now protect patient health information instead of protect electronic health information. But this idea of conducting a security risk analysis is something we're all familiar with already, and it will be sticking around. Although now everyone has to address encryption. Previously, Stage 1 providers were not required to, but since there are no exclusions or alternative exclusions for this measure, every provider is responsible for encryption from here on out. Cindy, do you have anything you want to add to this?
Yes, actually, this particular measure is one that I think gets overlooked a lot, and we've worked with a number of practices to try and assist them with this. You really need to go through the process. There are a number of questionnaires available online that you can go through, published by various entities, and basically questioning things like how is your email encrypted, what kind of things are you doing to protect, what kind of firewall do you have, is your data encrypted on the hard drives or your servers themselves. If you're hosted by a vendor or you have someone hosting you, make sure that you get a statement or form completed by them. This is something that needs to be done every year. It goes on in perpetuity, because as things change and as the rules change, there are additional questions that you need to do, and it's just extremely important. Once you have your statement that this has been accomplished, then you want to put this in your meaningful use binder and keep it updated every year.
Great, thank you. On to clinical decision support. So the objective, use clinical decision support to improve performance on high priority health conditions. The measure 1, implement 5 clinical decision support interventions related to 4 or more clinical quality measures at a relevant point in patient care for the entire EHR reporting period. Absent 4 CQMs related to EPM scope of practice or patient population, the clinical decision support interventions must be related to high priority health conditions. And measure 2, the EP has enabled and implemented the functionality for drug-to-drug and drug-to-allergy interaction checks for the entire EHR reporting period. For measure 2, you can be excluded if you write fewer than 100 medication orders during the reporting period. So it is being left to the provider's clinical discretion to select the most appropriate clinical decision support interventions for his or her patient population. The clinical decision support interventions selected should be related to 4 or more of the CQMs on which providers would be expected to report. The goal of the CDS objective is for providers to implement improvements in clinical performance for high priority health conditions, hoping to result in improved patient outcomes. There is an alternative objective and measure for any EP who is scheduled to participate in Stage 1 in 2015. They may satisfy the following measure instead of the modified Stage 2 one you see on the screen. This alternate exclusion is to implement 1 clinical decision support rule that is relevant to a high priority health condition, along with the ability to track compliance with that rule. So we are starting to see the alternative specification and exclusions I kept mentioning in the beginning for providers who are scheduled to be in Stage 1 this year. Now, Kathy, did you have anything you wanted to address regarding clinical decision support?
Yes. Nextgen does provide a white paper on this measure which shows recommended screenshots for the meaningful use binder. Nextgen does not offer a turn on or off functionality for the clinical decision support roles since it is an attestation measure. An attestation pop-up is accessible from view in the top toolbar of the EHR when a user is related to self and system admin. This pop-up shows the DUR display levels, and a copy should be placed in your meaningful use binder each reporting period.
Great, thank you. So computerized provider order entry. The objective, use CPOE for medication, laboratory, and radiology orders directly entered by any licensed health professional who can enter orders into the medical record per state, local, and professional guidelines. For measure 1, more than 60% of medication orders created by the EP or authorized providers during the EHR reporting period are recorded using CPOE. For measure 2, more than 30% of laboratory orders, and measure 3, more than 30% of radiology orders. You can be excluded individually from meeting each of the above measures for the ones that you have fewer than 100 orders during the reporting period. So for those of you who qualify to attest to an alternative measure because you are scheduled to attest for meaningful use Stage 1 in 2015, for measure 1, more than 30% of all patients with at least 1 medication in their medication list seen by the provider during the EHR reporting period have at least 1 medication order entered using CPOE. Or more than 30% of medication orders created by the EP during the reporting period are recorded using CPOE. And then providers scheduled to be in Stage 1 in 2015 may claim an exclusion for measure 2 and 3 of this modified Stage 2 objective for EHR reporting period 2015. And providers scheduled to be in Stage 1 in 2016 may claim an exclusion for measure 2 and 3 as well for EHR reporting period in 2016. So to reiterate, if you are a provider that is meant to be in Stage 1 in 2015, you can claim an exclusion and you do not have to meet measure 2 or 3 at all for this year. Kathy, you can go ahead and chime in here with any other information you may have.
Within System Admin, there is an ability to mark and identify credentialed staff members. If marking a staff credentialed, keep a copy of their credentials in your meaningful use binder for the reporting period. So you have verification of that staff member's credentials.
All right. Electronic prescribing. The objective, generate and transmit permissible prescriptions electronically. The measure, more than 50% of all permissible prescriptions written by the EP are queried for a drug formulary and transmitted electronically using CERT. You can be excluded from meeting this objective if you write fewer than 100 prescriptions during the reporting period, or if you do not have a pharmacy within your organization and there are no pharmacies that accept electronic prescriptions within 10 miles of the EP's practice location at the start of your EHR reporting period. To highlight why this objective is still being reported on and is important, CMS talked about the use of electronic prescribing having several advantages over having the patient carry the prescription or the provider directly faxing handwritten or typewritten prescriptions to the pharmacy. These advantages include providing decision support to promote safety and quality in the form of adverse interactions and other treatment possibilities, efficiency of the healthcare system by alerting the EP to generic alternatives or to alternatives favored by the patient's insurance plan that are equally effective, reduction of communication errors, and automatic comparisons of the medication order. It is important to note for the purposes of this objective, we are adopting that prescriptions for controlled substances may be included in the definition of permissible prescriptions at the provider's discretion, and where the electronic prescription of specific medication schedule is permissible under state and federal law. This is just to point out one of the reasons why the wording has changed to permissible prescriptions. So again, there is an alternative measure for Stage 1 2015 providers, and it states that more than 40% of all permissible prescriptions written by the EP are transmitted electronically using CERT. So it's the same thing, just taking that threshold down from 50% to 40%. Cindy, you can go ahead and address any other Nextgen information that's important to e-prescribing if you'd like.
Absolutely. One of the things about permissible prescriptions is the fact that you can now include controlled substances now that many of the states are making this available. We've worked with several states on the dual authentication requirements, and some of them have different areas that you have to accommodate. If you're not doing this and it's something that you've shied away from, or perhaps it was something that you couldn't meet your measures because many of the prescriptions that you do prescribe are controlled substances, this is now an opportunity for you, and it's something, simply reach out to Nextgen, question your state, federal guidelines, make sure you have everything that you can do. It's really quite nice, and the clients that we do have that are using it are very, very happy, and I would definitely focus on your controlled substances. I think everybody on the call, in terms of looking at that, has been doing e-prescribing for a long time and understand the benefits of that. This is probably a pretty easy measure for most of you to make. Definitely, though, take a look at the controlled substance aspect of it this time.
Great, thank you. So health information exchange. The EP who transitions their patient to another setting of care or provider of care, or refers their patient to another provider of care, provides a summary of care record for each transition of care or referral. The EP that transitions or refers their patient to another setting of care or provider must use CERT to create a summary of care record and electronically transmit such summary to a receiving provider for more than 10% of transitions of care and referrals. You can be excluded from meeting this objective if you transfer a patient to another setting or refer a patient to another provider fewer than 100 times during the reporting period. So this was retitled from Summary of Care to Health Information Exchange and has retained only the second measure of the existing Stage 2 Summary of Care objective. The proposed updates to this measure reflect stakeholder input regarding operational challenges in meeting this measure and seek to increase flexibility for providers while continuing to drive interoperability across care settings. Previously, the measure specified the manner in which the summary of care must be electronically transmitted, stating providers must electronically transmit the summary of care or use a nationwide health information network exchange participant, or send it in the manner that is consistent with the governance mechanism of ONC. So this measure was updated to state simply that a provider would be required to create the summary of care record using CERT and then transmit the summary of care record electronically. In addition, all summary of care documents used to meet this objective must include the following in order to be considered a summary of care document. Must have the current problem list, the current medication list, and the current medication allergy list. So an EP must verify these three fields for current problem list, current medication list, and current medication allergy list are not blank and include the most recent information known by the EP at the time of generating the summary of care document. And finally, providers scheduled to demonstrate Stage 1 may claim an exclusion for this objective and measure since Stage 1 has no equivalent measure that they would be planning to meet at this time. Kathy, I know you have some information regarding this objective you may want to share.
Yes. In order to meet health information exchange, at minimum, an eligible provider using Nextgen will need to install Nextgen Share. Nextgen Share allows secure direct email messaging to another provider of care. Nextgen Share, once installed, can be accessed from the referral template as well as the medical summary utility. In order to implement Nextgen Share into your Nextgen environment, you must be at version 5.8 UD1 or higher.
Great, thank you. So patient-specific education. Starting from here on out, I know we are running out a little bit of time. We will provide these slides to everyone, so instead of going through and reading through the objective and the measures, I'm going to go ahead and highlight the exclusion and then go ahead and go through those notes I'm providing. So with the patient-specific education objective, you can be excluded if you have no office visits during the reporting period. So CERT is permitted to use the patient's problem list, medication list, or laboratory test results to identify the patient-specific educational resources. The EP may use these elements or additional elements within CERT to identify educational resources specific to the patient's needs. The EP can then provide these educational resources to patients in a useful format. So it can be an electronic copy, a printed copy, even an electronic link to the source materials, or through a patient portal. For EPs, the measure states only that the patient had an office visit during the EHR reporting period and was provided patient-specific education. This could refer to materials provided during the office visit or at another point in time. Therefore, we believe that while the patient-specific education resources may be provided outside of the EHR reporting period, this action must occur no earlier than the start of the same year of the EHR reporting period, if it's less than 1 full year, and no later than the date of attestation. So to clear up the timing questions of when the materials must be provided, if it's a 90-day reporting period, they just need to be provided within the same year as the reporting period and not actually within those 90 days. But if you are reporting for a full calendar year, then yes, the materials need to be given within that year, not necessarily at the time of the visit though. There is an alternative exclusion for those planning on stage 1 in 2015. While the patient-specific education objective is designated as an optional menu objective in stage 1, the same objective is mandatory in stage 2. We do expect that not all stage 1 scheduled providers were planning to choose this menu objective when attesting in 2015. Therefore, CMS proposes that any provider scheduled to demonstrate stage 1 in meaningful use for 2015 who is not intending to attest to this stage 1 patient-specific education menu objective may claim an exclusion. So this was offered as a menu objective for stage 1. If you weren't planning on picking this one to fulfill it, then you may claim an exclusion for this measure. Cindy, did you want to add anything else?
Yes, just as it relates to Nextgen, in this particular area, as most of you I'm sure on the call know, HealthWise is the supported patient education tool that Nextgen provides everyone. However, you can use your own. And if you are using your own or using HealthWise in a more independent perspective, as what I mean by that is not using it from the links from the templates or the methodologies in place from the templates that allow it to be counted and stored in the chart, you can actually go ahead and document this in My Plan, and this is where you would put it in. And as we stated it basically, can be done at any time during the calendar year. And that would be something that would be very, very beneficial for everyone to know, that you just have to get this education out.
Right. So medication reconciliation, to highlight the exclusion, you can be excluded if you are not the recipient of any transitions of care during the EHR reporting period. So what exactly is medication reconciliation and why is it important in CMS's perspective? Well, they are now defining medication reconciliation as the process of identifying the most accurate list of all medications that the patient is taking, including name, dosage, frequency, and route, by comparing the medical record to an external list of medications obtained from a patient, hospital, or other provider. Medication reconciliation allows providers to confirm that the information they have on the patient's medication is accurate. And it not only assists providers in his or her direct patient care, but CMS highlights it's also improving the accuracy of information provided to others through health information exchange. So with this, providers can claim an exclusion if they were planning on doing stage 1 in 2015, but This again, if they did not intend to select this stage 1 medication reconciliation as one of the menu objectives they were going to complete, then they're excluded. Kathy, could you please chime in on this one for some Nextgen details?
Yes, for medication reconciliation, and any template that has the medication module grid, you have the ability to click on the EHR medication reconciliation. And this is the reconcile button for medication review, and a pop-up will populate for the user so that they can reconcile each of the medications that the patient is currently on.
Thank you. So for patient electronic access, so the goal of this objective was to allow patients easy access to their health information as soon as possible, and so that they can make informed decisions regarding their care or share their most recent clinical information with other healthcare providers. The ability to have this information online means it's always retrievable by the patient. So the download function makes sure that the patient can take the information with them when it's not available online. In order to meet this objective, the following information must be made available to the patients electronically within 4 business days of the information being made available to the EP. So you need to have the patient name, the provider's name and office contact information, the current and past problem list, procedures, lab results, current medication list and history, current medication allergy list and allergy history, vital signs, smoking status, demographic information, care plan, including goals and instructions, and any known care team members, including the primary care provider. So providers may claim an exclusion for the second measure if for an EHR reporting period in 2015 they were scheduled to demonstrate stage 1, which does not have an equivalent measure. So again, that's just for that second measure. Anyone in stage 1 this year will be able to claim an exclusion for this. Cindy, I know, is one of our Nextgen portal experts. You have some information to share on this.
Yes, actually I want to talk a little bit first about measure 1, and this is the more than 50% criteria. This is basically giving your patients access to the portal, whether you're using the Nextgen portal or you're using a third-party portal. So many of you have been utilizing the token methodology, and that's one that is a bit of a challenge because you can give the patient the token, but you can't necessarily get them to actually come back in and register, and that's not a full registration. We have been working with a number of our practices to be able to do auto-enrollment through Nextgen, and that is a functionality that actually will take the patient based on encounter and other criteria that you can set up. You do have to have some template work and SQL work done in this, whether you have the capability in-house or you need to contract out for that. It's pretty minor setup associated with it, and what that will do is that will actually go out and scan the database for any patients that are not registered in the portal that have had a visit, and they will get the information out based on criteria, as I said, that you set up. So that's a way to meet this measure because the patients are actually then set up and registered and given a login and an ID and a security code that they can go in and change their password, much like when you register on other entities. So that's been a feature that's actually made this measure more achievable. In measure 2, it's just at least one patient seen by the EP during the reporting period to view, download, or transmit their health information to a third party. That's going to require the patient health record to be turned on. Since this is only at least one patient, all you would need to do here is turn this functionality on in your system and then do a screenshot because it is self-attestation. And then what would happen there is that you would need to put that in your meaningful use binder. This measure has been a really big challenge for everyone in the past, and this changes to the measure have made it a lot better, and auto-enrollment has made it a lot easier to achieve without the token.
Great, thank you. So secure electronic messaging. So there are some exclusions here. You can be excluded if you have no office visits during the EHR reporting period, and you can be excluded if you conduct 50% or more of encounters in a county that does not have 50% or more housing units with 4 Mbps broadband availability, according to the information that you can find on the first day of your EHR reporting period. So first off, I wanted to clarify that CMS has set out a clarification of what fully enabled means, and that means that it is fully installed, that any security measures are fully enabled, and that the function is readily available for patient use. CMS has removed the stage 2 threshold of 5% and instead requires that the capability for patients to send and receive a secure electronic message is fully enabled during the EHR reporting period. However, there will be a phase-in approach over the period of 2015 through 2017 to the stage 3 threshold in 2018. So basically, we can see here in 2015, the capability needs to be turned on. In 2016, we see the threshold increase to 1 patient, and then in 2017, we see that threshold increase again to 5% of unique patients. So this is basically, we see a kind of work a step-by-step toward a high goal. It's important to establish that incremental change from that basic to advanced use and increase thresholds over time. So therefore, CMS is finalizing that it's fully enabled for 2015. Again, a threshold of 1 patient for 2016 and a threshold of 5% for 2017 to build toward that stage 3 threshold. I do want to point out that the calculation may include actions taken before, during, or after the EHR reporting period, if the reporting period is less than 1 year, aka 90 days. However, these actions must be taken no earlier than the start of the same year as the EHR reporting period and no later than the date of attestation. And finally, an EP may claim an exclusion for the measure if for an EHR reporting period in 2015 they were scheduled to demonstrate stage 1, which does not have an equivalent measure. With this kind of falling under the same portal use, Cindy, did you have any other comments you wanted to make?
Yes, again, this is another self-attestation role, and Nextgen does accommodate this with the secure messaging within the portal. A lot of the groups that are using portal do not have this turned on for obvious reasons, being able to email back and forth with the patients in a secure email environment, and they didn't really have to set up a workflow and being able to do that. So the nice part about this is it does allow you to self-attest in 2015. You simply need to turn this on, send and receive a secure message to show that it is enabled. Nextgen does have it enabled. You've got your routing set up, even if it's just a basic medical question. Then you can do your screenshots for that without getting into the whole marketing to your patients, etc., and you can gradually ease into it. While this has been a scary area for a lot of groups, the bottom line is that once you get it done, they've actually been very, very positive about it.
Great, thank you.
Hey, Lindsay, I'm going to jump in for just a second here. Hey, everyone, it's Chelsea. Looks like we might run over a couple of minutes, but I do see all of your questions coming in, and we do have answers for them. If you need to leave at the time that this ends, we are recording it, and I'm going to be sending out a link to the recording along with a link to the slides that you can download later. So if you need to catch up on it later, that will be an option. Thanks, Lindsay.
Thanks. So lastly, public health reporting. This has changed from the proposed rule and has been scaled back a bit. We can see the objective is here and the measures. So in the proposed rule previously released, there were 2 separate measures for public health registry reporting and clinical data registry reporting. So this was originally done to better define the potential types of registries available for reporting. Now we see this has been switched back to specialized registry reporting, which contains now both those 2 I just mentioned. So this was changed because it was believed that specialized registry reporting better encompassed both those registries. And they basically, CMS said it wanted to prevent the inadvertent exclusion of certain registries through the attempt to be more specific. So we usually had 5 reporting measures, and we scaled it back to 3. The other reporting measure we're missing was actually case reporting. And this happened after deciding the readiness and standards of case reporting were not mature enough to be included yet. This will come back in finalized stage 3, but it is no longer available for the modified stage 2 measures. I also want to point out that in 2018, syndromic surveillance reporting will no longer be available for EPs as it is being removed. It's still here now. It's here until 2017, but in 2018, it will no longer be available. So you can see this is the same kind of chart, the maximum times a measure can count. We have, for specialized registry reporting, you can have 2 separate measures. They just need to make sure they are separate. For example, if a provider meets this measure through reporting to both the National Hospital Care Survey and the National Healthcare Safety Network Registry, the provider could get credit for meeting both those. They just need to be different. And in reference to that line underneath the table that says there are exclusions available, well, it is finalized that an exclusion for a measure does not count toward the total of 2 measures. Instead, in order to meet this objective, an EP would need to meet 2 of the total number of measures available to them. So if the EP qualifies for multiple exclusions and the remaining number of measures available to the EP is less than 2, then the EP can only meet 1 objective. If no measures remain, then the EP can meet the objective by claiming applicable exclusions for all of the measures. So just because you have an exclusion for one doesn't mean you have one down. You need to get two unless you have no other options. So the exclusions I'm referring to and how you would get those, they refer to situations that render the provider unable to report to a registry due to a reason outside of their control. So some of those reasons are if they don't diagnose or directly treat any of the diseases or conditions associated with the registry. For example, if they don't administer immunizations at all, or it's not a category where syndromic surveillance is collected. Basically, this means if the measure is not appropriate for their clinical scope of practice. Or if they operate in a jurisdiction where no registry has declared readiness to receive electronic transactions. This means all of the registries are closed for meaningful use reporting, or after the start of the reporting period, you still can't find any. But it is important to put out that you do, after the start of the reporting period, you must register your intent to report within 60 days. If you don't have any registries that are capable of accepting the information, or you have not declared readiness, you will be able to be excluded from this measure. What I want to stress here is that it is the responsibility of the provider to retain all of the evidence that the objective was met, which includes all of the documentation that supports an exclusion. Do not assume based on your specialty that as a provider you don't need to collect the information. Make sure you're doing your homework. Check with your state for any reporting opportunities. If you are a specialty practice and don't know where to find this information, contact your specialty society and see if they know. And then keep those efforts you're making for your future audits. And there is an adjustment for an EP who's scheduled to be in stage 1 in this year. You must report at least one measure unless they can exclude from all the available measures. And stage 2 EPs must meet at least 2 measures in 2015. And by 2016 and 2017, everyone will be meeting 2 measures. Kathy, I know you have some information you wanted to share.
Yes. Nextgen currently has interfaces available for immunization registry and syndromic surveillance. They just announced last week that they will be introducing Nextgen Clinical Registry Service. You will be able to choose from several available specialty registries, as shown. Utilize one connection from Nextgen Share to all available registries. And Nextgen Share is a self-installed, simplified implementation process. These specialty registries will not replace syndromic or immunization interfaces. At this time, they are for future consideration. Nextgen states that clients may register intent with these registries for 2015 meaningful use reporting. Testing and implementation dates to be announced. Pricing is based on what individual registry charge. Most charge subscription, some charge installation and participation fee.
Great, thank you. So let me go into this active engagement. This is a new wording that's being used instead of ongoing submission. I'm not going to read through this in its entirety. Just know the reason they changed this is to try and better capture the provider's actions and give more credit. So we have different options here. Option 1, which is completed registration. Option 2, testing and validation. And option 3, production, to now capture what a physician is doing in order to do public health reporting. So basically, CMS is trying to make sure everyone's effort this year don't go to waste, and any work or preparation that's been done is still valid and will count towards your meaningful use measure. So CMS did point out that any work you've done for public health reporting this year in the past for ongoing submission will still count towards active engagement, and they'll find a way to fit it in and make it count. So we have the finalized objectives here. We have the modified stage 2 versus the stage 3 objectives. You can see for stage 3, we have 8 objectives for eligible professionals. You can see the first 4 match up, and basically you see kind of that funnel of modified stage 2 funneling into stage 3 and becoming a more condensed and compact version of it. Stage 3 will see more measures per objective. We won't go into detail on that. I will go ahead and talk very, very briefly about just the important facts about stage 3 next. So just some quick facts. There were some changes made. The CPOE and e-prescribing measures decreased from 80% to 60%. Coordination of care measures decreased, all back down to 5%. Public health reporting, again, we see decreased from 3 to only 2 out of the 5 measures. Also, that final rule includes a 60-day comment period on the stage 3 portion of the rule. We talked about this earlier. The reason they are doing this is to receive input just on stage 3 and basically try and include that input into MACRA and see how those rules are going to flow together. And then in order to attest to meaningful use stage 3, you will have to have the cert to the 2015 criteria, which I did mention earlier, and that did, again, just get released about a week ago. So the 2015 participation and reporting. So again, we have this continuous 90-day period within just this year. You can attest, providers can attest for EHR reporting period beginning on 1/4/2016. This is because the site is currently down. CMS needs to update their system for the new attestations that are coming in. And then for the EHR reporting period, all Medicare providers must attest by February 29th of next year. And then again, cert to the 2014 criteria is necessary, and you do still need to be submitting your CQMs. Just the CQM basics. All it's really worth pointing out here is that for the EHR reporting period 2015, all APs may attest for any continuous 90-day period. Again, like I said, this doesn't need to match up to the meaningful use 90-day period. It's okay if it does. Then we have the Nextgen HQM. So this is interesting. The Nextgen clients use HQM for all meaningful use and CQM reporting. So just to cover briefly what's happening, you can see stage 1 users, they're being automatically enrolled in stage 1 measures for the modified rule and stage 2 modified measures, as well as being put in the meaningful use 2 program. Stage 2 users are being automatically enrolled in modified stage 2. All users will need to complete new configurations for adding or removing measures, changes to date ranges, and new measures listed. The only thing we do have is that we wanted to clarify, and we are researching what Nextgen means by automatically enrolling in the Meaningful Use 2 program. There is some ambiguity there. Please, for now, don't take it as they're automatically enrolling or testing you for anything. Right now, we're going to assume this is referring to HQM reports only, and we will get back to you with more information regarding this. All measures, including the removed ones, will remain in the HQM. The core and menu naming convention will be changed. It'll be tossed out. But all the measures, even the ones that are removed, will still be there. And finally, the #1 question on everyone's mind, the final rule was released so late. What if I can't meet the modified stage 2 meaningful use requirements for 2015? Well, CMS states that you can apply for the hardship exception under the extreme and uncontrollable circumstances category. So CMS has stated they intend to use their administrative flexibility as much as they can to help providers who are making efforts to adopt this technology. So they are encouraging providers to submit requests for a significant hardship exception through the normal way they usually would. So take action now. Just some things you can do right now as you're getting started. Confirm your stage. It's important to know what stage you're at, so you know if you know that you have the alternate exclusions and accommodations being made for you, that you can take advantage of them. Check your registration information, login, payment, just to make the process go by a lot faster and easier. All right, we made it. I know it was a lot of information to absorb all at once. Thank you all so much for listening. I know this did go a little bit longer than expected, but we are going to go ahead and I believe open it up for questions. Chelsea.
Hey, Cindy, do you want to take it first? Cindy, I believe you might be muted.
Yes, sorry about that. There have been a couple of questions that have come in about the patient electronic access, and I wanted to clarify something I said. I mentioned auto-enrollment as being able to accommodate the 50% measure easier than if you were generating it with a token at a time. There are 2 measures here, and one of them involves the access of the patient health record. If the patient health record is turned on, because the measure states there that you have to give them access, if it's turned on, it shows you made the attempt by giving them a token. So the token does count in that case towards the 50%. If it's not, it doesn't. So my advice is for everyone to turn that functionality on, because that solves both problems. I was not clear in the way I stated that, so I wanted to clarify that because we had 2 questions associated with that. So the providing the patient the token does count because you've given them access provided the PHR is turned on.
Thank you, Cindy. Okay, so moving on to the beginning of the questions. How and where is the attestation done? Kathy, do you want to take that one?
Sure. The eligible provider will attest via the CMS attestation portal. The portal will be available beginning January 4th, 2016, and they will be able to attest to their 90-day reporting attestation through February 29th of 2016. That's the deadline. There is a registration process, as we discussed earlier in the presentation, that should be done prior to the attestation itself.
Great, thank you. Okay, question number 2. If a group is unable to attest for Q4 2015 to Stage 2, what are the options to catch up in 2016 and going forward? Kathy, that one sounds like a you question again.
Okay, so if the provider does not meet meaningful use in 2015, CMS is recommending that the EPA file a hardship application. Under the criteria, as stated earlier, that it was unforeseen circumstances, they are using they're being more lenient this year on that specific hardship statement, unforeseen circumstances. So that's the recommendation. And then moving forward, of course, all of these hardship applications are pending approval, but then moving forward, you want to make sure that you successfully attest in 2016 and so on.
Great, thank you. Next question. Are there any changes to CQMs? Cindy, you want to take that?
That's an easy one. No, there are no changes.
Thanks.
I like
Next
this question.
Next question regarding e-prescribing. What is meant queried for a drug formula? Kathy?
In Nextgen Medication module, you have the ability to query the patient's drug formulary. You need to have your formularies installed and turned on. And if you do so, then when the eligible professional is prescribing a medication, they should query that drug formulary from the medication module to meet that criteria.
Thank you. Next question. What if others in your area don't have Nextgen Share? Kathy?
I'm going to actually verify this question. It is my understanding that in the past, CMS would allow you to send one test to their website. That no longer is available. So I will follow up on this question to see if there is any options for physicians. At this point, though, I believe they are requiring exchange from provider to a provider.
Great, thank you. And we will come out with those follow-up questions, any that we need to research a bit. We'll include those in the email when we send out the links to the slides and recording. Next question. Can we send encrypted emails? Cindy?
I'm going to take that, but as I'm reading the questions now, because we're now in a position to read them, I think this question is kind of a follow-up to the Nextgen Share question, simply because it was the same person asking both questions very, very quickly. I'm going to follow up on a little bit on what Kathy said. If others in your area don't have Nextgen Share, if they're on an EHR and they are attesting for meaningful use, they have to have some capability to accept some form of continuity of care document, which is what we call in Nextgen the referral letter. I think that may be the question. I may be expanding into something that isn't there. So if that's the case, if you've sent it, it's also their obligation to pick it up regardless of what system that they have. And I think that may have been the question followed on with the encrypted emails. As for encrypted emails, if you're sending encrypted emails to satisfy the continuity of care document, any of the other documents that are associated with sending these referrals, there's very precise information that has to be on these documents from the CMS perspective. So in my opinion, an encrypted email would not suffice for those measures. Now, if you can send encrypted email for other purposes, it's perfectly legitimate. I just don't think it achieves one of the measures of the meaningful use. And Kathy, if you want to jump in here, I think that's why being able to see the questions back to back, I think that's what we were stating.
I agree. At one point they were allowing encrypted emails. I think they took that away, and that's something we could research as well a little bit further for clarification. But I think you need a health information exchange at this point.
And Ryan, if you're still on the call, if you want to let us know if that was the question you were asking, and if not, clarify a bit, and we'd be happy to help you. Okay, next question. How about education and AP details? Will that count? Kathy?
I'm going to go back and research the white papers. I've had this question previously, and I do not believe it does, but I'm going to go back and verify. At this point, I believe patient education is through HealthWise, and on the My Plan template, the instructions section. I know there is some specialty pieces such as cardiology where specific education pop-up counts, but it's very specific to specialty. So I will go back and verify that question on the white paper as well.
Okay, thanks. And it looks like Ryan confirmed that that was the question. So we were able to answer that. Okay, next question. Can you still just click the meds that were reconciled, and can we reconcile them manually? Cindy?
Yes, that has not, the process in Nextgen has not changed.
Okay, great. Next question. Is there a checkbox that says education materials were given to the patient in the AP details? Does that count for educational meaningful use credit? I think that's the same question.
It is, and I think, yeah, we'll research it. I know that's been a challenging process.
Okay, next question. Do you actually have to fill out the Med Reconcile template, or can you select the Meds Reconciled checkbox and then reconcile them manually outside of the EHR to count for meaningful use?
I think that's the same question as before, and the answer to that is yes.
Okay. A referral letter is different from a CCDA as far as OPH goes. Is the CCDA that meets the transition of care measure? Is it the CCDA that meets the transition of care measure?
I've got this one, Kathy. The referral letter is not the CCDA. I blended those in the last answer, so from that perspective, that's probably where that came from. When I was speaking to the encrypted emails as to what that particular question was about, the referral letter is different from the CCDA, but it does still have specific information that needs to be included to count for the transition of care. So there's a referral document. Typically in most systems there's a referral document and a referral letter. You generally have to either do the referral letter or both in order to achieve the meaningful use. So I hope that clarifies that one.
Okay, thank you, Cindy. Next question. Is there an easy way to see if providers use Nextgen Share?
Yes. The best way to look and see if the providers use Nextgen Share, number one, is if you have Nextgen Share installed on your referral template, the simplest way to do it is to type in their name, and you'll see if they have a direct email account. If it does not show up there, if you're the administrator of Nextgen Share for your practice or enterprise, you can reach out first to the entity or the physician to ask their practice if they have a direct account. If they state they do and they give you that information, you are able to add that through the Nextgen Share website so that you have that available to you within the Nextgen application.
Okay, thank you, Kathy. Next question. When will the HQM portal reflect the modified stage 2 changes?
I was able to attend the Nextgen webinar on that, and we kind of went quickly through that slide. But from their understanding of it, they're already working on it now and should do within the next few weeks. They didn't give us a date. They said actually it was to be announced of when we could actually start testing and going through the validation process. But we will let you guys know as soon as we know from Nextgen and hear from Nextgen.
Okay, next question. How about the red monograph? Does that count for the education for meaningful use?
Kathy, I don't know.
Can you repeat that question one more time? I'm sorry.
Yep. How about the red monograph? Does that count for education for meaningful use?
Yes, it does. Within the medication module, yes, that is correct.
I just wasn't sure.
Yeah. Yeah, it does.
Okay, next question. Will Nextgen Share count if you are sharing with a provider that is within your enterprise?
No, not internally.
Well, I'd like to understand the definition of enterprise. If it is internal, then no. I agree with Kathy, but understanding the setup, an enterprise can be a regional thing. I've got an enterprise that I work with today that is multiple practices, separate tax IDs, separate everything. They are basically a purchasing group that came together in an enterprise. Billing services could be an enterprise that they share the EHR, and in that capacity, then you are separate, distinct practices. So it's really, you really want to think about it as, if your enterprise is a single practice that's a multi-specialty group, then it does not count. And Kathy, correct me, I think I'm saying it the way that you're saying it. If you are totally independent entities, separate tax IDs, and basically are just sharing an infrastructure, then I believe it does count because you're totally separate.
Correct. Okay, thank you for that clarification. Stacy, the person who answered the CCDA question, that was Cindy Kincaid. So you can reach out to her. Her email address is up on the screen for further information. Again, wanted to clarify that the monograph in the red module counts for education. And it looks like this might be our last question. If none of our providers that we refer to use Nextgen Share, what are our options?
Again, I think this is really, and Kathy, again, jump in if I'm understanding. There are all kinds of HIEs and all kinds of entities within various states and organizations. You know, you can have someone who's not on Nextgen and using whatever their defined program is, whether it's Centricity or other things. You can send the referral document through using Nextgen Share to them, and then whatever methodology they have, they should have a methodology for it coming in. I can't tell you if they do. I can't tell you if it works. I can't tell you. You know, I've had individuals state that when they send, when they receive referral documents, you know, using another entity into Nextgen Share, that is then put into their holding tank, for lack of a better word. If it comes in that way, that from other entities, maybe they can't see it, maybe it's garbled, maybe there's special characters. That still, in my mind, counts because you're working through the process. Not everyone's going to have Nextgen Share. If you don't have Nextgen, while it's available to other entities, the whole purpose of interoperability is to be able to communicate back and forth with people regardless of the system they have. I mean, Kathy, would you agree with that?
I would agree. The receiving physician needs to have a secure email address, and that email address needs to be available within your search criteria. So in the Nextgen Share search, that email needs to be available. To clarify what I stated earlier, so for example, if I'm sending to Dr. Smith and he's using Centricity and he has a secure email address, if I search for him and he's within the Nextgen HISP, I'll be able to find him. If he is not within the Nextgen HISP, that secure email address does need to be added, and that's the piece where you can go in and add it to the Nextgen HISP so it's searchable through your Nextgen Share window.
And then however he receives it in really no longer becomes your issue. Now, you know, if he doesn't have it and you're sending a referral and it's something, this has been a common complaint I've had about Nextgen Share and just referrals in general, even if they have NG Share, a lot of them say, well, we don't check that. Or I called our referrals, I was working with a group, and they said, we called all our referring doctors and we've been sending it, but they don't actually call the patients because they don't check that, so we have to call again. We have to call and send it through NG Share. That's unfortunate, and you know, someone else's compliance really doesn't have to be your issue. You just have to make sure you're doing what you're supposed to be doing.
Okay, thanks guys. And it looks like we have another question here too. Is there an exclusion for stage 1 for HIE objective in 2015?
There is an exclusion. So for HIE providers scheduled to demonstrate stage 1 may claim an exclusion for this objective and measure, since the stage 1 has no equivalent measure that they would have been planning to meet at this time. So for 2015, they can apply for that exclusion and they want to do it, but then again, for next year, for that full year of reporting, they will be expected to do the HIE objective and measure.
Okay, great. Well, it looks like we've made it through all the material and all the questions. You can see everybody's information up there. And later this week, we'll be following up with an email to links to the slides and a recording of the webinar, as well as answers to the questions that we said we'd follow up on. Please feel free to reach out to us with any further questions. You can reply to the email that I'll be sending later this week with all that information, or to any of the email addresses up on the screen. And thank you, everybody, for taking your time to spend with us today. I know we went long. I hope that you found it useful. And you can always also reach out to us on social media to ask us any questions you have through that. Thank you so much for joining us today. Ladies, thank you for presenting.
All right, thank you, everybody. Goodbye. Have a great day.
Thank you.